practice is harvesting an organ, that's retrieval of organs from, of course, a brain dead person, is that concept itself. To a Muslim, the first question is that desecrating the body in the first place? And most of the sources are, that is not in any way disrespect or mutilation of the body. Then the next question, of course, is about whether the body itself, as the issue of now, the cardiac death or the brain death. So in overall now, with the issue we're talking about brain death, if most of us are clinicians, you understand, and that you can have circulatory death, which is the standard death, the body goes cold, and that is what Islam dissolvement, that is what we refer to. But the other issue, of course, is the issue of brain death. And in the search of the researcher, we found that the main issue, the ethical problem is not the issue of transplanting organ, or neither is it the issue of retrieving organs from the dead, from the brain dead person, or cadaveric transplantation. The main issue is the concept of the death itself. So when we talk about the brain death, if you go to ICU today and then someone has a discussion, I'm sure we've often come across, especially after trauma, you say the person is brain dead, therefore if we disconnect the machine, they will die. And in most cases, that discussion is had. So in countries that have cadaveric organ donation then, the next discussion normally will be, are you willing, before we disconnect, then are you willing to donate the organ? Has the person opted in? In some countries these days, there is also, that is a totally different topic, but that of opt-out, opt-in, as in some countries these days, you assume to be an organ donor if you've never cleared to say, I'm not donating my organs. But in most countries, it's an opt-in issue. So that discussion, that point of switching off the machine, mechanical ventilation, cardiac support, and also lung support. So the main issue, the main ethical question actually doesn't surround the issue of transplantation. The issue of, it's that issue of transplanting from the brain dead person, which now categorically, as I say, is a person in life support. And if you disconnect the machine, of course, medically we know after a few minutes the person will pass on. But if you allow that, then as I said, some organs like heart, lungs are totally unusable after cardiac death. Only probably kidneys and liver to some extent. So the current, organ transplant started in 50s, has been perfected over the years. The first kidney in 54, liver in 63, 67, but it only picked up in 80s with perfection of immunosuppression. So the current practice, and as pointed out, now if you check the Sunni Muslim world, Turkey and Saudi Arabia are one of the countries that practice most of cadaveric organ donation. That it's entrenched into their law and it's actually practiced. I think Turkey is where I trained, and they do an average of 1,000 cadaveric transplantation per year. Saudi is in the range of 100, 112. So for that reason, then, and what do they depend on for this decision? Of course, it's fatwas, especially the Saudi one is a fatwa by a conference of Islamic jurists back in the 80s. Egypt also has organ transplantation. They have a law, they passed in 2010. But as I said, because of the ethical question, and of course, the issue of, the Islamic jurists and clerics, especially standing against the issue, the questioning the brain dead aspect, that is where now most of the question is. And because of that, Egypt, despite passing the law, haven't actually started cadaveric organ donation. And as I said, and because of the same reason, if you look at the world organ donation, organ transplantation picture, as you go towards the East, because it's not just an Islamic or religious issue, it's also an cultural issue. When you look at what point the death sets in, you'll get more of living donor transplantations in Korea, Japan, or even Turkey, or even Muslim worlds. But when you go to US, UK, it's more of a cadaveric donation on that aspect. And during the search of this, we also checked how are they on that. They have laws. For example, US, there's a categorical law on, provided all the brain function has stopped, then that person is regarded dead, and therefore the organs the donation process can start, of course, with the consent from the family. Even they tried to change in 2022, try and consent, because as a clinician, the brain has, you have the brain stem. When you talk about the brain death, we're talking about the brain stem. When you have the cerebral hemispheres, that is coma, literally, when you have a death of that. But even in a point where you're saying this person is brain death and you're actually trying to implement that, there is another axis, the neuroendocrine axis, that doesn't stop. I mean, the person's hypothalamus and pituitary still regulate and continue. So the issue was actually that America was trying to correct that, say, the whole brain dead to a brainstem, and actually they had to suspend the process in the middle because they couldn't agree on those aspects as well. So it's not only an Islamic question, it's a cultural cross-cutting, and even in the modern world, an issue at that. So in summary, in the next part of the slide is now, this is just the data on what fundamental laws or what fatwas have been relied upon over the years by the Muslim world on the left-hand side to actually come to a conclusion of allowing both organ donation from living donors, starting with that, as I said, blood transfusion initially in 1950s, all the way to 1980s now, where they sanctioned, I mean, they allowed even cadaveric donation, and that's what some countries like Saudi doesn't have an explicit law. Turkey actually has an explicit law that allows cadaveric transplantation. Now, on the right-hand, sorry if it's a bit crowded slide, is the numbers. And as I said, places like Turkey are doing more than 1,000 per year from cadaveric donation alone. Saudi has now reached 112, 115, as I said. So the main question, therefore, in this picture is, to our understanding from the literature review is, yes, it's an ethical question, the issue of organ transplantation from cadavers. Cadaveric organ donation. And when I say cadaver, as I said, medical student will understand, a cadaver, but in this sense, it's just a brain-dead human donation. And the main ethical question, therefore, is not about the fact that you can get the body from that. Most of the literature, Islamic literature, actually says, no, it's not a mutilation of a human body, it's not a mutilation of a corpse. It's allowable because it's saving a life. The main question is actually the agreeing on whether brain death is actually death. And at what point if the person is warm, the heart is beating, the lungs are functioning, even if by mechanical machine, and it's circulating. Clinically, as a clinician, as a doctor, I can say you can get neurologists, neurosurgeons, and other, most hospitals actually, most regions require, jurisdictions require at least 3 specialists, anesthesiologists, a neurologist, a neurosurgeon, to come to a consensus that it's a brain death, then you can proceed with that. So the reason I raised this question is this. Recently, Kenya, a few years back, the KTTA, Kenya Tissue and Transplant Authority, and right now, of course, at the policy level, they're at that conversation of coming up with, regulations. We already have living donor donations in Kenya. You have kidney transplants being done. Liver transplant has not started yet, but kidney is being done. And I'm sure the conversation will move to cadaveric as well. I mean, the whole point of an authority is to come up with a kind of decision at the end of the day. So where do we stand then as a Muslim society when it's just a matter of time when somebody, a Muslim who is brain dead, will be asked, are you donating your organs? So what will be the answer? So the recommendation, of course, is we need to be engaged, both as an association, gratefully we have a KAMMP, and also as a society, clinicians especially, to be part of that platform, that conversation, so that you're not surprised by a relative calling you, they tell me they want to donate organs, what do I do next? So there's that question, of course. So implication, as I said, this conversation is ongoing, and KAMMP has to be, of course, be part of it as a body that represents clinicians, if they are not already, and acknowledge it as such. So as I said, in summary, the ethical issue surrounds the issue of brain death and not actually the issue of transplant itself. Thank you. I think I'm just on time.
Thank you. Although it's important to note the difference, like in the UK, for them it's brainstem death, whereas in the US it's whole brain death. Yeah, so I mean, it's like death has really changed. The same way as gender has changed over time. Yeah. So, Professor, are you willing to tell us, about Ibadah-friendly hospitals? Or was it going to be a panel for him, or? Yeah, okay. Karibu. You have a presentation? Okay. Okay. Mm-hmm. You have a slide, okay. Hey, sorry for all the confusion.
Yes.
So how long do you want?
maybe 15 minutes. I will rush in 15 minutes, inshallah.
Wait till the project is
Then, where is the pointer?
the pointer.
So maybe I should ask a question. Thank you very much for the presentation. Please, regarding the living organ transplantation, what do you said about reproductive organs?
Honestly, mine is more of a liver kidney transplant surgeon, but fundamentally, again, that also raises a different question altogether, because as I said, up to 100 plus uterine transplants have already been done, and penile is under 10. So it's a totally different ethical conundrum now when it comes to transplanting reproductive organ. I haven't seen any done within the Islamic jurisdictions yet, but I'm guessing when it gets to that, it's more of a totally different, because that is not even a brain issue, totally. But the understanding is the reproductive organ, you're not transplanting the seed or in any way the ova. That has also been with the VF, isn't it? So I haven't come across the literature on that specifically, but as I said, I'm guessing it'll create a different conundrum when it comes to ethical of that aspect. But I'm treating it as just another solid organ at this point, knowing the seed itself is not being transplanted.
Okay, thank you very much. But I think the consensus among the Islamic scholars that reproductive organs are not accepted for Muslims. So transplantation of reproductive organs is not, is prohibited, because it's hibzil nasl, that is protection of the progeny.
Yes.
If you transplant an organ from one person to another, you are transferring the genetic composition of one family to another who are not legally married. Okay. So just like in the assisted reproductive technology, you take a sperm from somebody to impregnate an ova for another woman who are not married. That also is not accepted in Islam. So this is the only caveat for the living organ transplantation. Thank you.
Thank you. Okay, please go ahead.
Okay, good. Thank you very much. I think I will have to rush these slides because of the time and the way everything is going. This is Ibadah-friendly hospital. Is it this one I sent? Okay, it's okay. Ibadah-friendly hospital model. These are the, the outline of my presentation. I will rush as much as possible. Probably some issues can be addressed during the panel discussion. This verse is important to us, just reminding us the purpose of our creations as human beings. And of course, this one is calling our attention to be, to perform the work of da'wah. وَلْتَكُمْ مِنْكُمْ أُمَّةٌ يَدَعُونَ إِلَى الْخَيْرِ وَيَأْمُرُونَ بِالْمَعْرُوفِ وَيَنْهَوْنَ عَنِ الْمُنْكَرِ وَأُولَٰئِكَ هُمُ الْمُفْلِحُونَ. So this is telling us some of the principles of, healthcare in Islam, where Allah has exempted a fasting, a sick person from fasting or a traveler. So the explanation behind that is to preserve the health of a traveler and also to not worsen the condition of a sick person. All this is trying to tell us what Islam, inform us regarding the health. Then, of course, the hadith which says, "All servants of Allah seek medical treatment, for Allah did not create disease without creating its cure." So it's like a call and guide. Of course, when we look at from the historical point of view, the delivery of healthcare started right from the time of Prophet ﷺ, where we know there was an established camp that treated, the victims of war. And of course, Prophet ﷺ gives significant regard to healthcare services. This is Rufeda al-Aslamiyah, who is known to serve at the head of the camp that treated the wounded companions of Prophet Sallallahu Alaihi Wasallam. And of course, that was regarded as the first military hospital in the history of Islam. Hospitals, actually, these are the terms Maristans. The way they look at the hospitals actually is a way of seeking blessing from Allah. And during that time, most of what is happening, actually it is the pious Muslims that establish hospital in an attempt to get closer to Allah. And look at the various reasons why they establish hospitals then, to honor the children of Adam, because Allah said, وَلَقَدْ كَرَّمْنَا بَنِي Adam. So they wanted to do something also to honor the children of Adam, Sadaqatu Jariyah, and of course as a form of waqf. Look at the history also during the Umayyad Caliphate. You know, one of the full-fledged hospital at that time has, it's a general hospital or specialized hospital with outpatient department, the eye clinic, casualty ward, psychiatric ward, and all the doctors and all the staff, they have their specific duties. And of course, sorry, what is happening? Look at this time, 319 years after Hijrah, which is 931 years. This is exactly what to describe one of the hospital. It has about 860 doctors in Baghdad. And this hospital actually, when they were trying to establish the hospital, they have to make an evaluation of the angles where it has less chances of infection. When they were asked to get a raw meat and put it in the four corners of Baghdad, and they said where you get it more preserved, that is the best site for a hospital. And all this period, there was nothing in the Western world. Actually, it corresponds to the dark age of the Western world, and this is the golden age of the Islamic world. These are some of the people, as you know, Ibn Sina, Ibn Abbas, Al-Razi, Abul Qais, Ibn Baytar, all of them who contributed significantly in the development of healthcare in the Muslim world. And these are some of the hospitals. Al-Mustashfa Al-Adudi in the year 371 after Hijrah. Al-Mustashfa, Al-Nur, all these. This lasted for almost 778 years before it was converted to a museum. These are structures of the hospital. Actually, then they say when you look at the hospital, it looks luxurious, like luxurious palaces, like elegant palaces. When you look at see the hospital from far, you know it's this hospital because they give significant regard to hospitals then. There are some of the specialization. The men and women are admitted in a separate wards. Medical and surgical conditions also are separate. They have very robust system of record keeping in those hospitals. Okay, good. Look at this Western misrepresentation. Say the first surgery performed by under inhalational anesthesia was conducted by this doctor in America in 1847. And this is all what is there in our, medical books. And this is a fact, actually. 800 years before this doctor, the Islamic Spains, Al-Zahrawi, and others were performing surgery by the use of chloroform on a cloth. When they put it and put on the nose, once you breathe in, you get to sleep. So look at this misrepresentation, and this is exactly what we are reading in all our books. And this is the reason why we need to change this perception. So now, Ibadah-friendly hospital, what is exactly it means? This is a concept that enables patient relative and Muslim health workers to observe their religious duties properly, especially 5 daily prayers when on hospital admission and on duty, respectively. Ibadah-friendly hospital presents a paradigm shift in the pursuit of excellence in healthcare delivery through holistic, value-based approach. It integrates physical, psychological, mental, and spiritual dimension into the patient care, while extending the same principle to the hospital governance and administration. By embracing this comprehensive framework, Ibadah-friendly hospital ensures that both clinical and non-clinical aspects of healthcare services are aligned to promote quality, dignity, and compassion at every level of institutions. Muslims generally are conscious about their prayers, but unfortunately, the trend is showing that significant number of Muslims on hospital admissions were not praying consistently. And of course, this is what to drag or attract attention of our Muslim brothers and sisters to embark on this concept of Ibadah-friendly hospital care. What are the goals? To achieve success in the present life and in the hereafter. For a Muslim health worker, patient, relatives, and those immediate involved to get closer to Allah. And of course, for us to act as the Khalifa of Allah on the earth. Allah said, Inni ja'ilun fil arudi khalifa. So the reasons why, specifically, patients were found not to be praying consistently when they are on hospital admission, Muslims. And this was observed not only in the non-Muslim countries, in the Muslim countries everywhere. So this is quite serious issues. And these are the various reasons, actually: ignorance from the patient and patient relatives, inability of the hospital management to provide basic facilities which assist patient in performing salat, ignorance of the medical staff in assisting patient to perform salat, and of course, presumption that we are all Muslim. So you as a health worker, you assume that I am a Muslim, this patient is a Muslim, so they know they should be able to pray. So with that assumption, we jumped significant number of them not praying. So this is from the Muslim point of view, the definition of health, complete state of physical, mental, social, and spiritual well-being. This is what is so important, and we need to, is actually putting the background of Ibadah-friendly hospital care. So in Islam, what is spiritual care? This is defined as a means of providing, receiving care, support, assistance, and empowerment, especially at times of need, which include sickness, vulnerability, and hardship, the extent and limitation of which is rooted according to the Islamic theological foundation. So this exactly is spiritual care. These are the areas where you apply, provide resources for patients to fulfill worship obligation, reflect on and restoration of the right of God and others, facilitate coping with illness and hardship. So now, this component, which actually is describing the spiritual care, chaplaincy. What is chaplaincy? A chaplain is traditionally a cleric or a lay representative of religious tradition attached to a secular institution such as hospital, prison, or other institutions. A chaplain's most important job is to provide religious services, spiritual guide, and counseling to those in need. A chaplain who works in a hospital or facility provide counseling and spiritual guidance for patients, their families, and even the hospital staff. So anybody who will perform this work is performing a spiritual services to a patient. So these are some of the work. I just brought this just to guide us in the remaining discussions. Ibadah-friendly hospital actually encompasses all this. The main Ibadah-friendly hospital concept, the Islamic hospital, Islamization of health services, Sharia hospital, and Islamic chaplaincy is almost revolving around the same thing. The only thing there will be some little differences. So this is a question. Are Muslim patients praying consistently while on admission in Kenya? I don't know who will answer this question. And you need to answer this question. So I'll give you my answer from Nigeria. Look at our survey. We found that these are the male, female. This is the duration of their admission. This is what we found. 31.3% of Muslim patients at that particular period were not praying on that bed. And some of them were dying like that. So for those that are praying, the few ones, those that know they should pray, these are the way. Some of them, they understand, they can stand, some on the chair, some on the bed, they already know, the few ones that were praying. So look at it. For those ones that were praying, the question is that, do you find it easy to pray? 50% of them, they said no. So despite their knowledge and their enthusiasm to pray, they found it very difficult to pray. And that is a Muslim community hospital, not in the Christian community hospital. If you are not praying, what are the various reasons for not praying? I am not strong, I don't know how to pray, no place to pray, various reasons. Some I will pray after, and that after will be in their grave. Yes. So now, if you are not praying Are you comfortable with the situation? Obviously, for Muslims, it's no. So over 95%, they are not comfortable. It means they are not spiritually okay during that admission. And this is exactly the spiritual care that we need to take consideration into. Then, of course, one of the questions to us, did Muslim staff on duty remind you when it is time to pray? Look at it, 75% they say no. But they will come and give them injection and other medications. In Malaysia, they got 25 to 80% of them, they are the ones who are praying. So in some places, only 25 that are the ones that are praying, 75 are not praying. So this is a serious issue. So why do we need to, why do we need to implement this? To provide, providing a system or platform for Muslims to perform their duties as servants of Allah, facilitate Muslim as da'i, prerequisite. We need to understand Islam as the complete way of life. We need to understand the concept of ibadah in Islam, and of course, all the other components. So I will rush through this slide. These are some of the implementation strategies experienced from 3 countries. But this is very old picture. I think when you look at it, who are these people? They are nurses who are taking over and handing over. And they are praying before they take over and hand over. We all know that the Christians are doing it. So it's not something different for them. It's only Muslims that were left behind. This is a prayer kit provided by our Muslim brothers in Indonesia. So when patient is admitted, they provide this kit for them to keep. This is a mat, praying mat, the water to perform ablution, the sand for tayammum and things like that. This is what it contains, and the book, Al-Ma'asurat, and this book is actually guidance regarding the fiqh of prayers for a sick person. This is the tayammum part, the sand, this calligraphy, the qibla direction in all the hospitals. Look at the religious officers who are the chaplains who are trying to, train in Kenya, who will be doing this work, guiding patients on their religious aspect. Of course, for those patients who are dying, what are we doing to them? Are we saying La ilaha illallah? We are called upon that to say, encourage our dying patient to recite La ilaha illallah. Man kana akhir kalamuhu La ilaha illallah dakhala al-jannah. Are we doing that? So this is a serious issue. Most of patients are dying like that. Look at the women, they are covered, breastfeeding women, so that not to expose their body. Religious officers going around, guiding patients on admissions. Of course, the health workers themselves, they need to know Islam. So they organize some cycles to learn about Islam. You organize some seminars for the staff for them to learn more. Of course, patient going to, teaching them how to perform ablution, tayammum and pray. Patient going for surgery. How many times do we sit and pray for this patient? For us, the surgeons, we know significant number of them are dying on table. Are we preparing them before they go to the theater? This is prayer chart. Zuhri, Asri, Maghrib, Isha, Subi. So for those who are on duty, to make sure after serving medication, your patient also has prayed. And this is part of the documentation in the hospital. Malaysia, they develop this ablution, help patients to perform ablution. Those that cannot, prayers on the chair, on table. So I will keep going around. I assume my time has gone, but this is all the pictures. Nigeria, we started aggressively in 2018, even though we started the sensitization in 2016, and we have visited significant number of the states in the country, including our neighboring countries, Niger Republic, Ghana, and some other West African countries. These are some of the step-down programs in various states, institutions, and units, cross-section of various programs that went on Ibadah-friendly hospital care, radio and television programs also on Ibadah-friendly hospital, various workshops actually. These are specific program. It's a day program that we teach and also go some field work, visit patients, find out what is going on. So, and later we come back. I think one of the conference that I was able to say something online. Some of our international students, some of the online programs. One of the recent programs in Niger Republic. So of course, from that time till now, we are able to conduct over 70, national public lectures, over 112 step-down programs, about 15 international presentations, 25 radio and television programs, of course, about 11 training workshops. What are the achievements? These are some of the curriculum modification in one of our School of Nurses. They introduced this, the Introduction to Islamic Perspective in Nursing. These are the content. First semester is a general study course. This is the second semester application of Islamic perspective in nursing management. These are the content. There are some of the cubicles that were converted to a prayer cubicles in some of our wards. Of course, what we notice, most of the women who had their babies in SCBU, they don't go with their hijab, because of prevention of infection. So we now mimic what they are doing in ICU. We now initiate hijabs so that they can use the hijab owned by SCBU, just like the way you can use a gown to go to ICU. And at least it will make them comfortable to cover their body, to go and see their babies. Some of the training of our liaison officers in various hospitals, distributing these prayer packs so that they can be, the contact peoples in their wards, guide their patient on how to pray. These are some of the sections on teaching how you can assist your patient to perform ablution and prayers. It's one of the Ibadah pack also we developed in Nigeria, which we keep it with our representative on the wards. These are various prayer cubicles now. They have been created within the ward so that those patients that are strong enough, they can get somewhere and pray. And this will encourage patients actually to remember and they can be able to pray. Modification, we realize most of our nursing uniforms were short sleeve for women, and that is not what Islam is expecting. So we actually deliberated and discussed so much, why do we put short sleeve? There are so many reasons from nurses, but the argument actually at the end, infection control is not by exposing your skin. The overall concept is to protect yourself first. So you now expose your body, and something splash on your skin. It's much better to splash on your clothes than to splash on your skin. So the argument is clear. So some of our School of Nurses started modifying their female uniform to long sleeve, which actually comply with the teaching of Islam. This is our ziyarah teams in some hospitals, going around, seeing patients, teaching them how to perform tayammum, and these are some of the dua when you come to visit patients. I will soon conclude, inshallah. This is one of my patients, actually. Incidentally, some times back, I traveled. When I came back, I met the patient not praying for almost 2 weeks. I say, why? He said, I am waiting for them to remove this chest tube. Because if they didn't remove the chest tube, I can't put my shirt, and it is not good. You can't pray without covering your body. This is his reason. So we just developed this initiative, an apron that has an open side. So the next day when we brought this to the next patient, I saw him even in the mosque. He carried his underwater silk container and go out to go and pray. So you can see as simple as these reasons will stop some of these patients from praying. Some of the literatures, pamphlet and books on the Ibadah-friendly hospital. So how do we do if we want to implement? We need to establish the Ibadah-friendly hospital team. We need to conduct step-down training. Advocacy, very vital, to the heads of units to understand the importance, and it's not conflicting anything. Then, of course, we establish system of visiting patients. That is where we found some problem, and we will be able to solve it. And along the way, we have to evaluate. We check what is going on. These are some of the prayer positions for sick patients. In case somebody said, I cannot pray, so they can pray whether standing, down. There are all the options. We take note of that. Of course, selected prayers when you are visiting patients. Patient in pains, Bismillah, a'udhu bi izzatillahi wa qudratihi min sharri ma ajidu wa hadir. Patient that died. You are there on duty, patient died. What is suspected of you as a Muslim, Allahumma ghafir li fulanin. If you know his name, call his name. Warfa' darajatihi fil mahdiyin, wa khluf fi aqibihi fil ghabirin, وَاغْفِرْ لَنَا وَلَهُ يَا رَبَّ الْعَالَمِينَ وَافْسَحْ لَهُ فِي قَبْرِهِ وَنَوِّرْ لَهُ فِيهِ. So read this prayer for him, even before his relative comes as a Muslim, in case they die. So for those that visited patients, la ba'asa tahurun insha'Allah, just to encourage patients that you're going to be okay. Then of course, as'alullah al-azima, rabb al-arsh al-azim, an yashfiyaka. If you go to visit any patient, this is what you need to say for that patient. So in conclusion, Ibadah-friendly hospital concept is a relatively new concept for the generality of Muslim health workers. Muslims need to turn back to their primary reason for their creation, that is to worship Allah anywhere they are, and to encourage others to do so. Effort has been put so far in sensitizing Muslim Ummah, especially health workers, about this concept and practice, which has done a lot of, the orientation. We have seen it. We have several other surveys to assess the knowledge of Muslim health workers regarding that. Several efforts are now geared forward by Muslim health workers towards implementation the Ibadah-friendly hospital care in various hospitals. We need more effort, collaborations, advocacies in order to promote the understanding and practice of Ibadah-friendly hospital care. Thank you very much.
MashaAllah, you've left us all in awe of those. We have a poster on prayer practices of health workers. I don't know how many of you saw that, which showed that about 68% of health workers delay Dhuhr or Asr prayer. Prof, I'm telling you that how do you get health workers to remind patients if they are not praying themselves? Yeah? So, because the poster, I don't know if you saw it, 68% delay the Asr or Dhuhr, and they have their reasons. It's like too busy, there's no place to pray, too much work, I don't know what. So it's not just messaging from the Muslim perspective. Next is, where's Dr. Bajaber? Yes? Yeah, it's the last presentation, at least for presentations, but there's still something else. Yeah. Yes, but it's very interesting.
Yeah, I'll make it very short. It's related to what Prof was talking about. It's something very new. Before the presentation goes up, I don't know who's... so how many of us have, just quickly, heard of a human milk bank? Human milk bank, okay. How many of us have heard of a human milk bank? Okay, all right. How many of us are okay with donating human milk? Before add this very quickly is that an announcement, and we promise, inshallah, and Prof is actually willing to get this to materialize, to help us get this materialized in Kenya. There's no reason that our hospitals should not have the basic tenets of practicing ibadah in our facilities. When we go and do our rounds, sometimes we step out because they're very loud prayers. This was in KNH during our trainings all the time. You step out because someone is praying for the patients. But you don't see Muslim coming to pray for this patient. So we are letting that go, and we should pick it up, inshallah. So I'll talk about the ethical and operational reflections from the Human Milk Bank at Pumwani Maternity Hospital in Nairobi, Kenya. So we want to look at the global imperative for donor human milk. And as you know, the mother's own milk is the first ever preferred form of nutrition to a neonate. But then in the absence of the mother's own milk, what WHO, UNICEF, American Academy of Pediatrics have recommended is the donated human milk as opposed to the formula. And we know the challenges that come with infant formula, the same. So in 2019, Pumwani opened their first human milk bank in the region, and actually in East and Central Africa, the only one. If you compare to our neighbors, not very far down, South Africa, they have over 70 human milk banks. Now, this last part was not part of the study, but I had to include it for the purposes of this conference. For Muslim communities, the practice of rada, we've had this, the milk kinship, introduces profound ethical and legal dimensions on this aspect. And the Islamic jurisprudence has established that milk sharing creates family bonds, and it impacts marriage eligibility and social relations, which now requires us to evaluate it very carefully. So this is a core ethical tension that is happening, and we'll see in many countries. So before we proceed, I just quickly want us to go through the process of the human milk banking. We start from training, support and counseling as needed, storage, transport, tracking, all these fall under milk handling. But before that, you have to have donor recruitment. You screen the donors. Does it pass? If yes, they express the milk. If no, support and counseling is needed. Then after milk expression, you have handling of the milk, you process the milk, then you allocate the milk. Now all these are components of these other. In milk expression, you have expression at home. This doesn't happen in our setup. Yeah, we only do facility-based. Then milk expression as at the human milk bank. Then now in processing, we have all these processes, the thawing and the pulling of the milk. Pulling is where you collect from different mothers, different amounts, then you store together. Treatment or pasteurization and fortification. We don't do fortification in Pumwani Human Milk Bank. And then in treatment and pasteurization, you have screening. Pre-pasteurization, you screen. And post-pasteurization, you also screen for different pathogens. Yeah? Okay, now that we've understood that, the objectives of this study was actually to determine the level of conformity of the human milk bank. This is a human milk bank set on global standards. What are the global standards? And what we have here in Kenya, does it conform to the global standards? And what are the deviations? And then as a secondary objective was the infants that received this donor human milk, what are their social demographic and clinical characteristics? So in methodology, the study design, this is a descriptive mixed methods. We combined the path audit toolkit to measure the conformity, and then we looked at retrospective data on the infants that have received the donor human milk. We had 562 recipients from 2019 to 2022. Done in Pumwani Maternity Hospital, one of the largest maternity hospitals, over 1,600 deliveries a month. Yeah? And then the analysis was conformity weighted scoring against a set toolkit that judges whether a human milk bank is operating according to the established guidelines or not. And then for the infant characteristics, we used our analysis. So the assessment domains, as I said, is staffing, adequacy, infrastructure, quality, hygiene, protocols, milk collection, traceability, and so on. Now, this is the toolkit that we developed. I don't know if it's clear enough, but anyway, these are some of the sections that were adopted from the existing PATH guideline toolkit. So is there a human milk bank team leader in the facility? Is there infrastructural support? So yes or no, yes or no. Now these are the domains: staff conformity, facility conformity, the milk collection, milk handling, milk processing and allocation. The overall conformity came to 91.7%, which is 88 out of 96 domains. And I'll have to explain a few things on the missing domains here. In representation, we don't have a community liaison. We do it within the facility. There was a challenge with hygiene equipment, but this is not operational challenge in the sense that what is provided by the guidelines is not exactly what we have in our setup, which does not really affect the quality, because if you say what is recommended is a pedal trash can and they have the normal dustbin, then we need to discuss on those issues. So this is basically the summary of the results. And identified operational gaps, as I said, 50% conformity score reflects specification differences rather than safety failures. Community engagement, we didn't have this component. And the biggest part, and this is on the secondary objective, is lacking information on the recipients. We had about 299 excluded because it was physical register and we could not get the details of the infants receiving. So then another thing is on the allocation of the donor human milk, it's recommended for the sick, the small and the sick newborns. Now look at this data. 39% of them were low birth weight infants, not extreme low birth weights or very low birth weights. 43%, the highest percentage was term infants that were given the milk. 66%, the reason for giving this donor human milk was delayed lactation, which brings a very big question on lactation support. 20% was due to maternal illness, and then 5% due to social vulnerability. Now, this is in regards to the 50% hygiene score. What is recommended was powder-free gloves, and what was there is standard latex gloves, foot pedal operation bins, lidded waste containers, disposable paper towels, single-use serviettes. So on the discussion part, I think we've mentioned this. We need policy frameworks, technology infrastructure needs, we need digital tracing of these units, because there's a register that is physical that has the IP numbers, but all the other things you need to make decision on whether the human milk bank is working, you have to transfer that IP number to the register, the CIN network, to get all the other details. Community partnership development, and so on. Now, we come to the practices in Muslim majority countries. In Iran, the operational approach was government-supported human milk banks integrated into public health systems. What is the key ethical mechanism? Comprehensive, traceable donor-recipient records maintained under religious scholarly supervision. In Malaysia, the Sharia-compliant human milk banks, actually certified as Sharia-compliant human milk bank, mandatory registry of all the donor and recipient identities, prohibition of anonymous milk pooling. So the ethical dilemmas are two things: identification and milk pooling. You know, because different scholars say different things. You know, there are those, I think the Maliki and Hanafi are very strict about this, that any form of human milk, and yeah, I think I've mentioned it somewhere here, yeah? Yes. It's in this next slide or something, yeah. But anyway, in Malaysia, so that's in Turkey, community-based milk sharing projects are established within the Islamic guidelines. UAE, Qatar, Saudi Arabia, it's restricted or suspended milk banking operations. National fatwas prohibit anonymous pooling to protect lineage. Indonesia, hospital-based, strict documentation requirements with long-term record retention for kinship tracking. Now, this is just a pictorial of the same. Turkey, no human milk banks in Turkey. Plans abandoned due to cultural concerns. Milk kinship in Islam. Focus shifted to promoting breastfeeding alternative methods. This is Iran. Iran has human milk banks, and I said they are strictly Sharia compliant due to tracing. Bangladesh, none. And Pakistan actually opened for 10 days, and then a fatwa was issued because they couldn't abide by those regulations. So this is what I was mentioning. Hanafi and Maliki position, any quantity of human milk bank that reaches the gut is a form of prohibition. In Shafi and Hanbali position, 5 distinct feeding sessions. So this is the argument that the proponents say, that when you do milk pooling from one mother, it doesn't come to complete 5 feeds. Yeah. So recent progressive fatwas, Singapore conditionally permits human milk bank if complete donor-recipient identity mechanism is maintained for 21 years. This is the position of Indonesia and Turkey, similar conditional acceptance frameworks requiring transparent documentation. And Malaysia, Sharia compliant with mandatory registry system and prohibition of milk mixing from multiple donors. So key Islamic organizations, we have the OIC, fatwa in 1985, issued a fatwa prohibiting anonymous milk banks due to the inability to track and prevent prohibited marriages. European Council of Fatwa and Research It supports conditional, requiring detailed record keeping and clear communication. And the Islamic Medical Association of North America advocates for the establishment of the banks with stringent ethical guidelines. And the National Fatwa Council, such as Malaysia and MOIS of Singapore, approve Sharia-compliant human milk bank models. So 3 ethical pathways that we can see from this. Prohibited model, complete prohibition. Yeah. Then you have the conditional permission model. Then you have the pragmatic adaptation model. You develop hybrid registry systems, and then you also look at the milk pooling aspect of it. So, and the unifying principle is very, we know the Maqasid Sharia. Hifz al-Nafs, preservation of life through essential nutrition. Hifz al-Nasab, protection of lineage and family structure. Hifz al-Aql, application of reason in balancing competitive values. These are Maqasid Sharia that affect the human milk banking. So implications for us as Muslims and KAMMP, maybe opportunity for national leadership. KAMMP, in partnership with Kenyan Muslim scholars, can co-develop a nationally endorsed fatwa and operational guidelines that positions Kenya as regional model for faith-sensitive healthcare innovation. We've advised this, as I mentioned, I've been called to the technical working group for human milk bank in Kenya for this specific reason. They identify the challenges with the Muslims, and they want us to look at mechanism in which we can make it compliant to the Muslim faith. Policy integration framework, see how issues of Shah and so on would come into this. Ethical issues, some would say, do they need to be paid for that? Regulation issues, is it a tissue? You know, is it a biologic? Or it has not been established yet, yeah? And interfaith stakeholder engagement for the same. And these are my references. Shukran, Jazakumullah khair.
Thank you, Dr. Bajabir. You didn't tell us what proportion of those infants who got at Pumwani were Muslims.
It reflects what Dr. Saade was saying. There's no, we actually,
You're documenting.
religion, but none of the 600 was religion.
Exactly. So, yeah, because we need to know the uptake of the infants, those who are coming to the beneficiaries. We need to put religion, because then, you know, those Muslims, you'll have to really be strict. Yeah, but yeah, I just wanted to highlight that if you go to YouTube, Muslim_health, you'll get our podcast recording with Professor Salisu, Dr. Bajabir, Dr. Ifat. So you'll get 1 hour discussion about the 5 W's of Ibadah-friendly hospitals. What, why, where, when, and who. And so we want to do part 2, and you'll also see links to other podcasts I've done with Dr. Fatma on the medical curriculum and medical ethics. So it's a podcast series, Muslims_health, that we're trying to build more awareness on this Muslim health as a subject and as a discipline. Dr. Bajabir, I'm done, I think. Yeah, so.
Shukran. Jazakumullah khair. We'll have a quick panel discussion on the Sacred Trust. And our panelists, I would introduce them. I think due to the program disruption, and we know how these things go, one panelist has something to do in the afternoon and had to leave. Sheikh Abdul Latif was coming, but he got caught up on something else. And so we have 2 remaining panelists done the same. Actually 3, but Dr. Saade pulled out because her issue that she was to address was already addressed by Professor Shaukat in length, and that was on research. So allow me to introduce the 2 speakers. So the first one is Dr. Mohsin Sharif, who is a public health expert, and he's also the CEO of CHEPS. How many of you have heard of CHEPS? How many of you? He's looking at you. What does it stand for? Oh, you only know CHEPS. Yeah? So he's the CEO of Centers for Health and Education Programs. And then the second one we have is our just ended speaker, Professor Salisu. Please, Professor, come. Professor Salisu has so many titles. I think he'll forgive me for not introducing all of them. But he's a cardiothoracic surgeon from Nigeria. He is lead in FEMA Save Hearts. He is one of the founders for Islamic Medical Association of Nigeria, the Ibadah Friendly Hospital Initiative in Nigeria. And so he has a wealth of knowledge. So you'll allow me, I'll just go through one round of questions, and for the panelists, please let's try and keep it short so that we're able to catch up with the program. So our panel title is Sacred Trust in Medicine, History, Ethics, and Humanitarian Service. And I'll start the first question with Dr. Mohsin Sharif, who is a public health consultant, CEO of CHEPS. Daktari, what does humanitarian service teach us about medicine as a sacred trust? And how do you think, short-term medical missions evolve into sustainable community health systems?
Thank you. Bismillahir Rahmanir Rahim. Assalamu alaikum.
Salam.
You've asked multiple questions at the same time. Let me take it one at a time, and there are different dimensions. So the first question you asked was, what does humanitarian action teach us about medicine? So the first thing is that it reveals that medicine is not just a profession. It's a calling. It's a sacred trust. And where do we get that sacredness out of it? Obviously, our main constitution, our reference point is the Quran and Hadith and the Seerah of the Prophet himself. And that makes it really a sacred trust. And that means that as Muslims, we need to honor that trust. Now, humanitarian action, how do we define humanitarian? I guess what you meant was we generalize it to say anything good we do to other human beings in our medical practice, correct? Right, and because in certain international settings it is just taken as disaster relief, but in this context we mean as Muslims generally doing good in our medical practice to other human beings in need. And that means that it makes it a real moral and spiritual imperative. So the difference in the usual practice in medicine and where we take it as a humanitarian action, and the teaching from that in our practice is really that bit of what are we doing this for? And as in the previous lectures, we have seen that it has to be within the context of our Creator, alignment to Allah, and the meaning of life itself. And as we heard about Ibadah-friendly hospital, it has to be our Ibadah-friendly life. Our whole life is Ibadah, whether medical practice or otherwise. When we go out and perform a good action in humanitarian activities, we do learn that stems from that very niyyah. And when we start, we start with Bismillahir Rahmanir Rahim. Right? And we praise Allah for the opportunity that has come along that we provide that service. So instead of arrogance, instead of rejection, it turns into humility. and compassion and love. I find it that as Muslims, when we imbibe the real teachings of the Quran, not just reading it, but reflecting on it and try to implement it in our lives in the sense that it comes naturally and that anybody observing can actually see that look, this is what the Quran is teaching us. And as I said, when we start with Bismillahir Rahmanir Rahim, we see an issue, we see a problem, we see a person in need. The first thing that comes is Alhamdulillahi Rabbil Alameen. We praise Allah for the opportunity that we have got. Who is Allah? Ar-Rahman Ar-Rahim. How in our action is that now reflected? The mercy that we show to others as mercy has been shown to us. Not just in the general way of Ar-Rahman, but in a specific way. Who is it from? Maliki Yawmiddin. So our accountability, the way we do things, what we do we really seek it out? Do we go out of our way to do it? Because that is the pleasure of Allah, that we are accountable to Him. At that time, Maliki Yawmiddin. Iyyaka na'budu wa iyyaka nasta'in. Right? Ihdina as-sirat al-mustaqim. So we seek guidance, and we know guidance is of different stages. But in this case, in this surah, the opening, it is the highest level of guidance that we are seeking. So that He guides us and gives us tawfiq for actual action. And that is how, as we are practicing, as we are helping people, as we are doing it, if we practice what the Quran is teaching, even if it is just this Surah Al-Fatiha, it will start coming naturally. And then imagine if we use that teaching in our medical practice, in whatever other activities we do, it will reflect the actual essence of the Quran and Ibadah of Allah subhanahu wa ta'ala.
MashaAllah. Jazakallah khair, Dr. Mohsin. Dr. Mohsin has been leading a lot of community programs, especially in Chakama, an undeserved area. That brings me to a question, Professor Salisu, you talked about Ibadah-friendly hospital initiative. This is basically something that we do not have to be reminded. To have a lecture on the same is just institutionalizing Ibadah in our practices. But with this said, we work in Muslim minority places. Briefly, the press with time, and we've had a lot on the same. How do the non-Muslims feel incorporated when we practice Ibadah-friendly hospital? Or how can we make it all inclusive?
Okay, thank you very much, Dr. Abdullah. This is one of the common questions, and also something that is slowing down our Muslim brothers and sisters to implement Ibadah-friendly hospital care. So, and there was a time when we presented some of the challenges of implementation of Ibadah-friendly hospital care. And some of these challenges, we identify them as, I can say one of the challenges is the Muslim minority communities, then fear of the reaction from non-Muslims, or lack of intention or interest in doing the thing, or lack of knowledge. So not to go deep into those, if we go around these two. So first, many Muslims, if they are within the non-Muslim communities, they will think of two things. How do I bring this into the system? What will be their response if I bring this? Could they look at me as an extremist who is trying to bring Sharia in the hospital? So these are some of the things that are going on within the minds of people So then most of them, if they don't have answer, then they remain mute. So but what is important, ibadah-friendly hospital care is a very wide, concept, and you can apply it at various levels. At various levels. First, what is expected of a Muslim is to have the intention. You look at it, this thing, what you are doing or what you are going to do, first is a command from Allah. وَلْتَكُمْ مِنْكُمْ أُمَّةٌ يَدَعُونَ إِلَى الْخَيْرِ. And this is one of the khair, is to bring somebody closer to Allah. Scholars, some of them, when they translate this verse, because at the end of the verse it says, وَأُولَٰئِكَ هُمُ الْمُفْلِحُونَ. These are the successful people. So they regard them as the successful people on the day of judgment. So if that is the case, every one of us want to be among this group. So now, if this is a understanding, then every one of us must be a da'i. You must do something to bring people closer to Allah so that you can be successful in hereafter. So if that is the case, then it means you are staying with somebody, you need to call him to pray. Especially prayers is one of the major things. So, but relationship with Muslim minority, you need first, if you have the position, you need to bring them closer. Talk to them. If you are the head of the unit, talk to your staff. This is what is coming, and it relates to Muslims, and it will never, disturb any non-Muslims. This is one of our matron what she did. When she came back from a lecture, and she is heading a word, one of the words I show was the Kibukul for prayers, the first one, a woman praying. So when she went back as the head of the unit, she brought all her staff together. She talked to them about this Ibadah-friendly hospital, and she talked to the Christian staff. This will never affect you or your patients. They understood clearly, and she now did a lot of advocacy. She went and met the head of nursing. She informed them. She sought for permission. At the end, they gave her permission. So she now removed 2 beds from one of the cubicle. She put a mat and broke a trolley with some books and tayammum, and that is where patients are going to pray. And this is a female ward. So that understanding and effort, you can break that idea. But the presence of you as in a Muslim minority, position never stop you, even if nobody will give you permission. And you cannot bring your staff together, assuming you are the only Muslim. First, make it in your mind that I wanted to do this da'wah. Provided you will go and meet a patient, give medications, guide patients, counsel patients, is it difficult for you to say, have you prayed? Nobody will stop you from saying this in the world. Nobody, anywhere. Just to ask your Muslim patient, were you able to pray Zuhri? As simple as this question. If no, okay, try and pray. As simple as this. You can spend the whole life, even if you are the only Muslim in that community. Thank you.
Jazakallah khair. I think you've mentioned awareness is very important for them to know why ibadah friendly. So now I want to ask you a question, both of you, as a closing remark, a very brief closing remark. What can we do? I'll start with you, Dr. Mohsin, as Muslim healthcare workers, to embrace the humanitarian service in our communities to make things better. What are the practical steps? And for you, Dr. Salisu, on the same in the hospital setup, the next steps, even as an association, to take very briefly.
Bismillah ar-Rahman ar-Rahim. So definitely our religion is one of practical action, and whatever we learn and imbibe from that, we had to put it into practice, and it is our duty also to spread that word. Humanitarian action is really a key recommendation in, in Islam, and therefore we cannot get out of it. In whatever circumstances, context we are, whatever means we can do, what we really need to do is get out of our comfort zone. Oftentimes we make excuses because we are afraid of getting out of our comfort zone. And once we start doing that, making it a habit, and working with those we can influence, those we are close to, slowly the network increases. And then collaboration really is key, not just working for ourselves. That becomes a very selfish aspect. We have to remove all that. We need to see our niyyah is for the pleasure of Allah, and that means that we will forget ourselves when we are in the field, when we are working on an issue, whether we are working on removing stress in a human situation, or animals, or birds, or the environment in which people live. Imagine Sadqa Jariya is not about institutions only, but changing the whole environment, the context in which people live. That also is a long-term effect. We have climate change issues that are happening right now. So let's broaden that thinking. Let's collaborate together. Let's get up and out of our comfort zone and have that one main aim in mind, that it is really ibadah for us. Thank you.
Thank you very much. I think one of the important things that we all know, if we want to embark on the concept, practice and concept and practice of ibadah-friendly hospital care, first, we need to know that at least the concept of chaplaincy has been on several years in the Western world. So that is a backing for you. Whatever you will now wake up as a Muslim, I want to do this. So already that has been in existence and in the healthcare. So it's just to assure you that nobody will come and stop you except those who are enemies of Islam, who are always there to fight against Muslims. That is one thing. Two, even in your community, in most at times in our hospital, you will see them doing that. In fact, their own is the one that even disturbing. Whatever you will do to assist your Muslim patients, it will never disturb even his neighbor. So even if you look at it from that perspective, your own is calm system that nobody will challenge it. Above all, this chaplaincy has been recognized worldwide. So just to make sure that even if you are thinking of something else, the system is in existence. It's just you that you are left behind. Several years back, before I became the president of Islamic Medical Association of Nigeria, over 10 years, maybe almost 15 years now, when I became the president and inherited some documents, the chaplaincy program was introduced to the Federal Ministry of Health. But the outcome of that, it is the Muslim scholars that reject it, just because of that word, chaplaincy. So this is over 10 years after we embark on the sensitization campaign on the Ibadah-friendly. I say, how I wish this chaplaincy will come back now. It's even the safest way for everyone to practice his religion. And this is exactly one medical director, a Muslim medical director, when we concluded the training, is a Muslim minority, or is a mixed of maybe 50-50 in the community. So the head, the medical director, was a Muslim. So she attended the workshop, and in her remark, she said, I know how to do it. I usually quote that in my presentation. When they deliberated, because there are so many non-Muslims dominating in the hospital, she said, what I will do, I will ask the two groups, each one to bring his plan on how to assist a patient in their religion to be praying or to be doing their prayers. So when everyone submitted, then she will go ahead and approved. So indirectly, the Muslims that are not many there, they have gotten approval directly from the leadership, and they are free to go ahead with their activities. Thank you.
Jazakallah khair, Prof, for that. As we close, these two things have come out, collaboration, and no one can stop you from practicing your religion. So with that, that's all from us. This is a key discussion that inshallah should keep going on, reminding us of our sacred trust and our role in the community we get out of comfort zone. Let's give a round of applause to our panelists, inshallah.
Assalamu alaikum wa rahmatullahi wa barakatuh. We come to our end of the panelist. Now, I just want, on behalf of the organizing committee conference, extend our sincere and heartfelt gratitude to all our delegates, our speakers, our organizing team, and not forgetting our generous sponsors for making this conference remarkable. Your inside hard work support have enriched this conference, and it further strengthened our professional community and enabled us to host an event of real impact for medical fraternity. We really appreciate every contribution, whether through knowledge, resource provided, or commitment. As we close the conference, we celebrate the collaboration formed and progress made, and we look forward to building on this momentum together, inshallah. And we really thank all of you and safe journey back to your home, inshallah. Sa'a shukr.
You forgot to say, and with that, we declare. We had already closed, but officially closed. That was politically closed. Jazakumullah khair. We hope to see you again next year, inshallah. And sincere apologies for any shortcomings we've had on our side. Tuko pamoja, inshallah.
Assalamu alaikum. For those who have not had their lunch, they are closing at 3:30. So we have only 15 minutes to be there. Once you are inside there, they cannot remove the food. So please let us rush to have our food and prayers. Sincere apologies.
Give me the names. For those few who are here, just quickly to motivate us next year, there's some awards that were allocated for our presenters, the abstract presenters. So we have a winner for the best poster, and we have a winner for the best oral abstract presentation. And without taking much of your time, the winner for the poster presentation was oral presentation, best oral presentation in Dodori, and he will tell us quickly what he presented on. Ashraf Basi. And the winner of the poster presentation, if I'm not mistaken, is Dr. Sharif Saleh, all the way from Scotland, on ultrasound-guided removal of a needle. And I know he's around, but inshallah, it will be delivered to him. Is there any other? Oh, and this is a gift for this session. Best presentation that we actually think should have been yesterday at the opening, right? Ibadah Friendly Hospital Initiative. There is also an award for poster on prayer practices among Muslim healthcare workers. I think it's Dr. Onle. We'll give it to him, inshallah. Oh, the youngest presenter. I don't know if they're here. You guys have seen them through the program, yeah? They're twins, yeah, who have been confusing us. One presented an oral abstract and one presented a poster. So the best presentation goes to Abdul Naim Hussein. And it will be delivered. Dr. Abed has received, one of his mentors has received the gift for him. Even him. They are both from KUT RRH, yeah? And once again, sincere apologies for anything. Let's go have lunch, please, before tufungiwe. سبحانك اللهم وبحمدك نشهد أن لا إله إلا أنت نستغفرك ونتوب إليك. Thank you, Dr. Fatma, for sticking around till this time.
One, two.
1,000. How many dentists do you have? And pharmacists? Thank you so much.
And I guess we still have a lot of dentists who are looking for jobs as well. Thank you. Finally, last question from Ashraf, or comment.
Thank you, Mr. Governor, and you are most welcome to KAMMP. Shukran.
Thank you very much. I can do it from here, I suppose, right? Now, and on the people who are available, you know, that was my situation then. It has kind of changed. Because as I said, when I was talking there, we had only 2 doctors. Now we have over 70 in our payroll. The challenge we now have is to move from the center, especially for the specialists, to the sub-counties. They don't want to go to the sub-counties. We have a good pool of specialists, and there's some that are coming back from college, but there's some cadres that we're struggling. There's this program called the NESP, the National Equipment Services Program, which is replacing the MES. And we'll be flooded with quite some equipment between now and, say, January of next year. So radiologists are very few. You know, we're lacking radiologists. So, and very soon, probably I can take the number. Of course, we have to go through process and go through the adverts and all that, you know. But, you know, we can notify your secretariat when we're advertising those positions. In some of the specialist areas, our infrastructure development has not progressed as quickly as we were training people. For instance, we sent someone to go and train as an oncologist. And you know, usually what they do when they train and come back, they just bid their bonding time. Wanangoja 3 years, ikisha, wanatoroka. So you constantly have to have a pipeline. So the oncologists, we're now trying to negotiate with the national government to set up something for us. Someone said here, it's easier to come to Nairobi than to refer someone from Wajir to Garissa because of the road situation. Even that is improving over time. You know, the road is being worked on now, but for now we're still in a situation with respect to the roads. So I recruited 10 doctors this last year when we were doing the 212 nurses. We also did 10 MOs. For the specialist cadres, there are some cadres, I may not have all of them offered, that we don't have. We're largely relying on these people coming back, but the radiology might be a bit of an emergency. We may need a few more doctors when we officially open our level 5 hospital. We've put up a level 5 hospital, a new wing. They are moving in there bit by bit, but we'll need a lot more because it has 3 new theaters. It has an ICU section and a HDU section, an expanded ICU and HDU sections. So we'll need a lot of ICU nurses and a few MOs to go around. So those are things, you know, I'm sure there are members here from Wajir, I'm sure. Or they don't belong here. Then they'll tell you. As for the kind comment, thank you very much. Can you imagine if devolution was implemented honestly and sincerely in 1963? And you see, we're still being treated unfairly with respect to the big pool of resources that's left at the center. And these are conversations I usually have with the big boys. I usually tell them as it is. You know, they spend 5 billion shillings on heavy diesel. This diesel that powers standalone generators for those small towns in Wajir, Marsabit, and Turkana. A year. Fuel only for those KPLC generators. Isn't it easier to spend 30, 40 billion and just pull the wire from Garissa all the way to Mandera so that everybody's on the national grid? So devolution has done its bit to equalize us, but it can never really fully equalize this country. What will equalize this country is focused, intentional investments in these areas that have been left behind. Take electricity everywhere. Take roads everywhere. Open up the country. Take water to places that don't have water. I usually say in Kenya, where there's land left, there's no water. And where there's water, there's no land left to do anything. The average farm sizes in Vihiga are 1/4 of an acre. 1/4 of an acre is half a plot of residential plot in Karen, where Dr. Kelebi lives. What farming can you do on 1/4 of an acre? But we have huge land. So this country, if we get the right thinking and we focus on it, but our politics is so chaotic and toxic that it doesn't let anybody work. This is what we need to fix. Anything you try to do is politicized, and you know, of course, the political mobilization is along ethnic lines. So it's part of the challenge that we're facing. I've said on too many things. On the dentists, we have some dentists. You know, I assume they are doctors. So when I give doctors, I think they're included in that line. They're specialist doctors, aren't they? Yeah, so I know we have some. I don't have the exact figures, but of course, our worry is a lot more usually on, maternal healthcare and losing mamas to, during delivery and that kind of thing. But I can link you up with Dr. Somo, and, he'll tell you. I know we have some pharmacists are there, right? Pharmacists are there. Pharmaceutical technicians and pharmacists are there. So I want to end it there, and thank you. As I said, what I leave you with is, please, in spite of everything that you see in Kenya, in spite of our heightened consumerism, lead by example, inject a lot more humane into your humane, what do I say, and ethical practices into what you do to help us reduce taking people to Hawassa and to save poor people all this money they're spending in hotels and transport to India. I thank you, and may God bless you and bless your work, inshallah.
Governor, please join us here. The officials, please come quickly for a quick photo so that we can continue. Officials on the conference team. Fadal, you know yourself, please just come. The conference continues. We have 2 more sessions, very brief, of I think 5 to 10 minutes each. Please have a seat. The ladies. Come. Dr. Amina? Nabila? I think some people can stand behind. Amtatosha. Angalia, daktari, you need to fit. Wengine wasimame nyuma. Wewe kuja hapa kuna. Tatosha. Okay.
Al-Haajar TV, mwangaza kwa umma.